seat.
How are you all?
Apples are pretty good. Pretty relaxed. How about you? How's everything going? How's everything? Yeah, that's good. Yeah. We'll have to catch up some more. Yeah. And Edison's fun. Yeah.
I know I'll be hungry for this. I didn't think for a week.
Were you here on Monday? No. Oh, yeah. No.
Although that's like the link from. It's not the end of the world.
Oh wait, no, we can go on to YouTube.
I will leave you to get ready, and I shall catch up with you soon.
Today's the last day.
YouTube. What's the mental account called?
I'm kind of glad though, because like, it kind of stressed me out with the dogs.
It should be streaming to our main page.
And they all like,
Then,
Oh no! Woo!
Yeah.
Okay. Hey, look, that's us. Oh, this is gonna get very good.
Then,
Oh no! Woo! Let me host. Hey, look, that's us. Oh, this is gonna get very good.
Then,
Oh no! Woo! Let me host. Hey, look, that's us. Oh, this is gonna get very good.
then,
Oh no! Woo! Let me host. Hey, look, that's us. Oh, this is gonna get very good.
then,
Oh no! Woo! Let me host. Hey, look, that's us. Oh, this is gonna get very good.
then,
Oh no! Woo! Let me host. Hey, look, that's us. Oh, this is gonna get very good.
then,
Oh no! Woo! Let me host. Hey, look, that's us. Oh, this is gonna get very good. Good. I'm sorry, Jeff. There's no mess uploading. I'm sorry, Jeff.
No worries, I'm going to have to run at 22 though.
Okay, yeah, that's cool.
But we finished early yesterday anyway.
like my dad's like and gluten free. I was like that. I said maybe they'll be coming. He was like, yeah, that's actually lots of fast. Thank you.
I don't mind. Like, I got an express bus out
What?
front of mine.
Oh, yes.
But
Hey,
like,
last time.
Oh, my goodness.
Is this everyone we think we're going to get?
Probably. I'll look that up.
And it also feels like a mole.
Looks like some extra people. Yeah, we left when Lesh was left.
Yeah.
We completely forgot.
We're good.
But yeah.
That was so nice.
Really nice people.
were you there when we went there?
No, I wasn't there. No, it was like man fans.
Yeah, and then
No, I didn't make that day.
I think so. No, that's when that's the only time I
Do you guys want to come and sit here? We're going to be doing some like demonstration in this space. So. Do you guys want to come and like make a circle around this space? Because I'm going to demonstrate some stuff on some people instead of just talking to slides.
Are you doing this one as well?
Yeah. So same shit as yesterday. So I was... Well, fortunate. Or unfortunate, we'll see. No, he had work, and then Neela couldn't do it because she had hospital, and I was like, me again. Yeah, you guys are the lucky group. You've got the better version. Yeah.
Just write tech to It's just a whole extra version. It's so draining. Getting on the phone is so difficult. I can't have this drain.
guys, it's 10 past, so we might get started. Does everyone sitting behind the computers just want to come and like gather around the space, because I'm going to demonstrate some stuff on some people instead of just speaking to slides, because I think that's a bit more practical. Is anyone here who was here yesterday? Cool. My biggest fans. Thank guys. Okay, so this is a bit different to how other people have run them in the past, because I remember being a second year rep and being like, can you just show us some stuff? Like, we have the notes, we have the slides, don't just read off the slides. So I'm going to try and mix it up a bit. Let me know if it's shit and I'll do it better next time when I do gastro, but hopefully it's a bit practical. So a few things to start off. Firstly, this is my approach to OSCEs, and all of your approaches should be unique. It should be the best that you see of each person that's giving these tutorials, kind of wrapped up with your own personal style. So don't feel like you need to copy exactly what anyone who's running these tutes does. Secondly, when I was in second year, I just did not have my shit together at all. So even though like it might look like I know what I'm doing now, I didn't scrape through OSCEs. I did okay, and I didn't know much. So you guys will be better than I was, and that's how we're giving these tutorials, so that you guys can be better than we were. So don't panic if you're not at a fourth year level. You will be better than we were. And finally, group study is the best study, not just for OSCEs, but for everything. So if you can get a crew together, and like once a week is great, but don't stress if you're not up to that yet. A month out from OSCEs, if you have a solid group together and practice twice a week, then you will be fine. This is the marking criteria for the OSCE. If you haven't looked over it already, I would encourage you to look at it. It's in the back of your clinical skills guide. You will note that 5 of the things you get marked on relate to history, only 2 to exam, and only 1 to summary. So if you make a mistake in exams, if you don't know every exam 100% perfectly and every peripheral sign, don't panic. As long as you can kind of be a decent human and talk to other humans and not say anything grossly offensive, you will be fine. History. So again, your approach shouldn't be standardized, it should be personalized, not just to the patient and their history, but also to you and your communication style. Wipe was something that I used in every single one of my clinical exams in second year and in third year. It was a godsend, because sometimes you walk into a room and you forget like how to breathe and walk and do normal human things, and wipe will save you in this respect. So washing your hands is something that's actually really awkward in OSCEs. One time I washed my hands too much and they were like covered in water, and then I tried to hold the paper and it got really wet and I couldn't write on it. And then another time, like the sanitizer was outside of the room, so I was doing a skin station. I like did it as I came in, and then I went to touch her skin and went out and sanitized my hands and came back in, and then finished and went out to sanitize my hands and came back in. It was really awkward. So if you don't have sanitizer or a hand basin handy, just mime wiping your hands, because they just want to know that you have to do it. You don't have to like completely do the whole 90-second hand hygiene thing every single time. Just show that you're thinking about it. Introduce yourself in the examination and signposting the exam. There is a mark associated with this, so make sure you do that well, and I'll cover that again in a second. Permission is really important. Always seek permission for everything you're going to do, and let the patient know what you're going to do. And of course, position and exposure. Position, make sure you're doing it in a way that's comfortable for the patient, but also comfortable for you. So if you are about to do a cardiac exam and you lay them down on the bed at 45 degrees, and then you remember you have to take a history and look at their eyes, and you're like standing over them like this really awkwardly, especially if you're short, it's really weird. So think about what's comfortable for you as well as what's comfortable for the patient. And exposure, leave till the very last minute. Don't go, oh, we're doing a CV history and exam. Can you take your shirt off? So tell me about your home life and how are things? So last minute always. Have some standard phrases for your introduction. Hi, my name is, how are you today? Marking criteria 1 is sits down, creates patient report and checks patient comfort, and outlines an agenda for the time. So this whole thing is 1/8 of your mark, is just getting the hello, how are you right, which is pretty simple. Consent is really important, so always make sure at the end of your kind of intro spiel you say, is that okay with you? And that they say yes. And then have a really good opening line for segueing into your history. Everyone's can be different and should be different. My favorite is what's concerning you today, and that's through trial and error of a lot of different opening lines that have been really awkward. So some others that I tried in the past. What's brought you here today? And they always say an ambulance. What's concerning you? Oh, my son didn't make the baseball team. And it's like, no, like what's concerning you about your health? What's wrong with you sounds really awkward. Why are you here sounds really awkward. How can I help you? They might be like, oh, I need a more comfortable pillow, and like I don't know when I'm going to surgery. Can you help me with that? And what are your health concerns? They might start talking about what their health concerns are right now, or they might start talking about something from like 5 years ago that's not really a big problem. So what's concerning you today, I found is a really good way of finding out exactly what is wrong with them here and now regarding their health, but just find what works best for you. I will demonstrate what I think is a good kind of way to open. Can I have a volunteer patient to introduce myself to? Would you like to roll into the middle? Okay. Hi, how are you today?
Good, thank you.
My name's Dana. What's your name?
Nick.
Nick, nice to meet you. So, Nick, I'm a medical student. I've been asked today to do a cardiovascular history and examination on you. So what that's going to involve is having a bit of a chat about your medical history, your past medical history, and your family and social history. And then I'm going to move on to an examination, which will involve me asking you to remove your shirt and then having a bit of a look, a listen, and feel of your arms, face, and chest. Is that all okay with you?
Excellent.
Okay, so what's concerning you today?
I have some chest pain.
Fantastic. So, smooth opening. One thing you'll note, I didn't say, hi, my name's Dana, I'm a second-year medical student from the University of New South Wales, because no one cares what uni you're from. And also, everyone that's seen today is a second year. So it's a kind of a bit of waste of breath and a bit repetitive, and it's just like a trap that you fall into, and I think it sounds smoother if you don't say it. But if you want to say it, that's fine. So that's the introduction. Any questions regarding introduction? No. The next bit I'm going to skim over a bit. You all know the kind of way that you do your exam. Everyone has their own way. This is the way that I arrange it in my head. History of presenting complaint, past medical history, family history, social history. Other people might add allergies, they might switch social and family. It's all about doing the way that feels best for you, but also the way that flows best for the patient and the examination at hand. A lot of the stuff in this section, you're just going to have to rote learn for each section. Get yourself a good set of notes, go over it over and over again. So for CV, know your common symptoms, the 5 big ones: chest pain, palpitations, dyspnea, syncope, peripheral edema. For every single system, every single exam history, ask constitutional symptoms. So fatigue, weight change, appetite change, fatigue again apparently. There are some extras you can learn for CV systems. So I saw, this is like a collation of my notes and past year's notes. Someone wrote orthopnea and someone wrote P and D. I didn't really understand them properly and physiologically until 3rd year, so I personally would stay away from them. But as long as you know at least 4 of the top 5, then you're fine. You probably will be able to know the top 5 very easily and probably already do. History of presenting complaint. Socrates. You all know Socrates. It will become second nature. Just keep practicing it. Does anyone know the quote, when you hear hoofbeats, think horses, not zebras? Even Michael and Angie don't remember from yesterday. Yeah, you've heard it? Where's it from?
I don't know where it's from, but it means you should look for the most common thing instead of like something random.
Yeah, so like some doctor said it in the 1940s, and now everyone in the medical profession is like, this is great. I know it from Grey's Anatomy. But thank you, no one yesterday laughed. So know your horses. So the horses for the cardiovascular system. If I said I had central crushing chest pain, sudden onset, radiating to the left arm and jaw, no alleviating factors, what would I have? MI. Yep. Say MI, not heart attack. I once said heart attack and a doctor like ripped me to shreds. I have chest tightness. It's brought on by exercise and it's relieved when I rest or I use the spray under my tongue. Yep, stable angina. And if I have chest pain that just comes on sometimes and eventually it goes away, but when I use the spray under my tongue, it goes away quicker. Yep, unstable angina. So those 3 are the kind of the big ones in CV disease. There might be a few others in your clin skills guide that you learn. As long as you know the ones in the clinical skills guide, you can know a few extras. It probably won't make a huge difference, but know the basics essentially. For some systems, there are like zebras that you have to rule out, so the things that are really, really severe. This is just a fun pop quiz. So if I had pain on inspiration or expiration, what would you be thinking?
Like rest?
Yep, something related to respiratory system. If I had burning pain that's present at rest, non-exertional, and not related to respiration. Reflux. If I had positional pain that was worse at rest, prolonged, localized, and I had tenderness of my chest wall. No, strained muscle. This one's the zebra you need to rule out. So a severe tearing pain that's instantaneous. Yes. Aortic dissection. But these are not things you're not going to get aortic dissection in phase 1 OSCE. You might get gored. So make sure you know the difference between reflux and heart attack. Past medical history. So there are a few different approaches to this. The thing that I like to do and that I find flows really well is you kind of start a bit narrow and then you widen out and then you narrow it down again. So start with, we're talking about cardiac. Do you have any history of heart problems? And then kind of bring it out. Do you have any other significant medical history? And then narrow it down. Okay, so I need to show that I'm thinking about risk factors. Do you have any history of high cholesterol, high blood pressure, diabetes, heart disease, stroke? With regards to significant medical history, sometimes patients aren't very forthcoming. This set of 3 questions I found is a really good way to like bring things out of people. So you can say, do you see your doctor regularly about anything? Have you ever been admitted to hospital? And have you ever had any surgeries? And within those 3 questions, you'll probably get all of the past medical history you need to know. If it doesn't fall into those 3, you probably don't need to know it. I also ask medications and allergies in past medical history just because I think it's high yield, and you can also ask it at the time instead of coming back and say, oh, so you mentioned that you have asthma. Are you taking anything for that? You mentioned that you have high blood pressure. Are you taking anything for that? So it kind of just gets it all done at once. And then at the end of past medical history really quickly, do you have any allergies? No, move on. You don't have to know all of the medications either. Just know that they are on medications. I couldn't remember or pronounce a lot of the names of the ones that people said in my OSCE, so I just said they have a history of hypertension and hyperlipidemia, which are medicated. You don't have to remember the names of the medications. Considering the station is heart disease, I think it's really high yield to ask smoking, exercise and diet early on, so I would lump them with past medical history for the purpose of this exam. You know the questions you have to ask about smoking, just practice asking them for exercise and diet as well, just so they're a bit smooth. We'll get to them in social as well, I'll go over them again. The other thing with past medical history is to remember to use layman's terms with the patient and use technical terms in your summary and with the examiner. Family history is pretty much the same as past medical history. So any history of heart problems, any other conditions, and then rule out some specific risk factors. Social history. This is something that across the board people do poorly, and I definitely did poorly until last year. Is everyone familiar with HEADS? Yeah, you guys are, no, you've just finished BGDB. Yeah, so this is meant to be for teenagers and adolescent mental health in BGDB. I found that it's a good structure for absolutely any social history with absolutely anyone, and I like it because it starts out very like vague and general and then narrows down to the tough questions. So I'd love to demonstrate it on anyone. Can I have another patient to take a psychosocial history from? Anyone? Yep, cool. Roll into the middle. Okay, so remember your signposting. So you've already kind of told them what you're going to do throughout the history, so they know you've had a bit of a discussion already, and now you're up to psychosocial. So now we're just going to have a bit of a chat about your home life and how that affects your health and also how it's going to affect your management going forwards. So can you tell me a bit about where you live and who you live with?
I live in Sydney, North Sydney, with my parents and my sister.
Okay. And how's that all going?
It's good.
Yeah.
Chill.
Fantastic. And do you study at the moment?
Yes, I study medicine.
Okay, that must be really stressful.
Yeah, it's not too bad actually.
Yeah. And do you work alongside the study?
Yeah, I do.
Yeah.
I'm a retail assistant.
Okay, and how many days a week is that?
Usually 1, but sometimes up to 3.
Okay. And outside of work and study, what do you like to do with your free time?
I play sport on the weekend and see my friends.
Okay, fantastic. So with your sport, how many times a week do you exercise?
I have netball once a week, and then depending how bothered I am, I might go to the gym during the week.
Okay, so how many times a week would you say you have 30 minutes or more of exercise?
At least once, 1 to 5, depending.
Okay, a bit variable.
Yeah, very variable.
Okay. And you mentioned you like to go out with your friends. Do you drink alcohol at all?
I do, but recently not much.
Okay.
Yeah.
So on average, how many standard drinks would you say you have in a week?
On average 0.
Okay.
Yeah.
And do you ever have any kind of big nights where you have more than 4 standard drinks on one occasion?
Yeah, if I do drink, I drink to excess.
Okay. and how often is that?
Like, at the moment, probably like once every 3 months.
Okay.
Yeah.
And do you smoke at all?
No.
Have you ever smoked?
No.
Okay. And have you ever used illicit substances?
No. I mean, I tried a Nang once.
Okay. So just the one time?
Yeah.
Okay, not a problem. And have you ever used prescription medications for non-prescription purposes?
No.
Okay.
Yeah.
And I won't ask you about sex and sexuality in front of the class.
Okay.
So you can see it kind of followed the flow of the heads. So you start by asking about the home, and then you expand to ask about how they spend their time. Do they study? Do they work? And then what do they do outside of that, which is a nice segue generally into alcohol and exercise and diet. I didn't ask about diet. But it's just like a nice flow, and it's a good structure to keep in your head to come back to if you need to. Yeah.
Are you supposed to ask about sex and sexuality in a cardiovascular exam?
I'm told in phase 1 you don't need to. I'm also told that it's always good to ask. So in my phase 1, I had a 56-year-old woman who came in with like leg pain, and I asked her if she was sexually active, and it was really awkward. So only ask if it's relevant in phase 1. Yeah. And then suicide and depression. So sex and sexuality and suicide and depression. I got some questions yesterday. It is a tough thing to ask about. So I have 3 questions in my arsenal for each of them. I really like 3s. You'll notice everything is in 3s. So sex and sexuality, you ask, are you sexually active? Are you using contraception? Are you concerned about STIs or pregnancy? 3 easy questions. Suicide and depression, have you had any mental health problems? Have you thought about self-harm? Have you thought about suicide? But with all of those, obviously, if they say no, then you don't have to move on to the more tough questions. But you shouldn't have to ask that in phase 1. General history tips. Does anyone here meditate? Yes, nice. All like registrars have told me that you should meditate throughout your medical school and your training, and it's amazing. And I try, but it's hard. But everyone should definitely try at least twice between now and your OSCEs, because it really will make you less stressed, especially because at the end of second year you've got those 4 exams, one after another, and it's really rough. Has the sheet that David and I made been shared, the tips for end of second year exams? No? Okay, there's a page in the drive that's got like a list of tips for end of second year exams. Follow that sheet and meditate twice. One Giant Mind is a really great app. I would recommend you download and use that to learn how to meditate. But I really like how that kind of parallels how we do a history. So you kind of go with the flow. You have a bit of a structure, but you kind of take where the patient takes you. And occasionally you go off into tangents, but you just gently kind of bring yourself back. Don't like jerk yourself back. So just don't say like, okay, we're talking about this, we've gone off on a tangent. Okay, so do you smoke cigarettes? Like just kind of jumping back into that if you've gone on a tangent to talk about their home life and talk about their diet, and then suddenly jumping back can be really jarring. So make sure if you go off on a tangent, you bring it back gently. Remember your open-ended to closed-ended questions. Markers will be really, really impressed by this. Most people can't do it effectively at a phase 1 level, so don't stress about it, but if you can do it, it's really impressive. It also makes things a lot easier. So like with the head structure, you generally should by that point in the consultation know who they are and who they live with. So you can say, oh, you mentioned that you live at home with your husband. Can you tell me what that's like? Instead of just saying generally, what's your home life like? So if you ask open-ended questions, you'll gather a lot of extra information that you can pull into your history. But it is tough because you're trying to remember your structure, you're trying to remember to take it with the flow, and you're trying to remember your open-ended to closed-ended questions, and it's like a lot of stuff going on at once. So just don't stress too much about it, go with the flow, and kind of have a checklist in your head, but don't be too rigid about it, if that makes sense. It's tough to do everything at once. Use layman's terms for the patient, medical terms in the summary. Summarize and signpost as you go. So if at the start you've said, we're going to be talking about first your current complaint, then your past medical history, then your family history, and then your home life, then you can say, okay, so next we're going to, as I said, talk about your family, and it won't be so jarring and so unexpected. I sat in on a first year or second year once who was taking history and was talking about ophthalmology and this eye pain disorder has been having, and then suddenly said like, so have you ever used illicit drugs? And she was like, whoa, what? Where did that come from? So make sure you signpost so that the patient knows what's coming. Above all, don't panic. If you can just talk to a person reasonably, you will pass. That is 5 out of the 8 marks. That is what you need. The exam, the whole section is worth 2 out of 8 marks. I don't know where it says 9. So again, don't panic if you don't get things 100% perfect. You will probably get them well enough to pass. Just kind of show that you're thinking critically is the important part. Examination approach, same for every exam. So general observation, patient observation, peripheral stigmata, exposure and position, inspection, palpation, auscultation. So look, feel, move is the general kind of approach that I keep in my mind for all of the examinations. And obviously there are add-ons like look, feel, move doesn't include listen, but you kind of feeling, listening, sensing. It's how things work in my head. It's handy when you get to third year. I might demonstrate the examination on someone rather than just talking through the slides. Can I have a patient? You won't have to remove your shirt, if that makes things more appealing. Yeah, cool. Wheel into the middle. If you just have to sit in your chair, I won't move you around. So again, this is my personal way of approaching OSCEs. All of yours will be different, and every person that you see will be different, so don't feel like you have to mimic anything that anyone else does. Okay, so thank you for that discussion. Now we're going to move on to the examination. So I'm just going to be reporting back to my examiner as I go. If you have any questions or are uncomfortable at any point, please feel free to jump in and let me know. Okay. So first I'm looking around the room. I'm looking for any ancillary medical devices, including ECG leads, oxygen masks, and walking aids. Next I'm looking at the patient. The patient appears comfortable at rest with no signs of pain or respiratory distress and no obvious muscle wasting or pallor. Okay, can I have a look at your hands, please? So I'm looking for any peripheral cyanosis, any clubbing. Capillary refill bilaterally is less than 2 seconds. No signs of pulmonary para-ala and no Janeway lesions or Osler's nodes, and no signs of xanthomas. Thank you. I'm just going to have a bit of a feel of your pulse. So pulse is regular and strong bilaterally with no radial delay. Okay, you can relax your hands. I'm just going to have a look at your face now. So again, no signs of pallor, no signs of xanthelasma. Can I get you to look up to the ceiling, please? I'm just going to gently pull down your eyelids. No conjunctival pallor, no malar flush. And can I ask you to open your mouth? Pen torch. And no dentition is good. Can I ask you to put your tongue up to the roof of your mouth, please? And no central cyanosis. Fantastic. So now I would ideally position the patient at a 45-degree angle on the bed with their shirt removed, but in the interest of patient comfort in this situation, I'm going to leave them as is. So having a look at the neck, can I ask you to look over here with your eyes and your head and up a little bit and just stay there relaxed? So I'm just looking for a double flicker of the JVP, which I actually think I can see. And I will measure the height from the sternal angle. I'll just check that that's the JVP by pressing and seeing if it fills. It didn't fill, it was probably the carotid. Okay, and you can relax back. I'm just going to have a feel. Sorry, my hands are a bit cold. Carotid pulse is strong bilaterally, and I'm just going to have a bit of a listen. No signs of carotid stenosis. Okay, now moving on to the chest. First I'm going to observe, so I'm looking for any chest wall deformities, any scarring or any trophic changes, none of which are noted. Next I'm going to feel. So first, so you basically want to feel all the way around the heart. On a female patient, you obviously can't feel directly over the heart. So one hand at the top, and then in the middle to the left of the sternum, and then at the bottom. And then when you're at the bottom, you can just there feel the mitral, so the apex beat. So 1, 2, 3, and then feeling the apex beat. Okay, and now have a listen in those areas. So first with the bell on the apex beat for the mitral valve, and then flip it around to the diaphragm and listen over the apex, in the tricuspid region, in the aortic region, and in the pulmonary region. Next, dynamic manoeuvres. So can I ask you to just roll over onto your left-hand side? I'm going to have another listen. And so again, bell and diaphragm in the apex beat. And now can I ask you to sit up and move forward? I'm going to have another listen. Now, inspiration and expiration. So on inspiration, you can hear the right heart sounds better. On expiration, you can hear the left heart sounds better. So pulmonary is left heart. So expire, breathe all the way out, hold, and listen, and then breathe all the way in and hold, and listen. Okay. All right, thank you very much for your time today. Would you like some help getting dressed?
No, thanks.
No? Okay, I'm just going to report back to my examiner now.
Okay. Sorry, so do you have to actually count the pulse rate? Or you just say it's like...
So this is controversial. In my OSCEs, I'm really bad at 4 times tables in general. So, and like 30 seconds is a really long time. So I just asked the examiner, can I have the pulse, respiratory rate, and blood pressure? And that was fine. You might get an examiner that says, oh, the blood pressure is this, the respiratory rate is this, take the pulse yourself. and then you'll have to go and do it. I would recommend doing it for 30 seconds because 1, math is hard, and 2, you're more likely to detect an abnormality if you're listening for 30 seconds than 15. Okay, we might go through the slides then. So, general observations of the room and the patient. If you get stuck and you can't remember specific things for each advice, ancillary medical devices is a good overall, monitoring equipment is a good overall, and oxygen and walking aids. So you can basically say those 4 things for every single system. Looking at the patient, alert, comfortable, and no signs of respiratory distress is again relevant for every patient. You can then go into specifics about muscle wasting and jaundice and pallor, but if you get those 3 things, they know that you've checked that the patient is well enough to do the exam. If they're not alert, if they're not comfortable, if they're in respiratory distress, then they're not appropriate to do an exam on. Peripheral signs, there are heaps of them, and there's really detailed pathophysiology for all of them, and you don't need to know it, especially at phase 1 and not even at phase 2. So if you pick 2 or 3 things that work for you, I tend to have 3 on the fingers, 3 on the palms, 3 on the hands themselves. Again, rule of 3s, but just pick a few things that are really key. Clubbing, obviously, everyone knows. You can do the whole like holding up like this, but if they have clubbing, like you'll feel by running your finger over their nail beds. That's a list of a few of them that came to the top of my mind when I was writing these slides, but you can go into tallies, you can go into your phase 1 guide, just pick the ones that you like. Palpating, so capillary refill is important to do. Ask for vitals, which I did forget just then, so pulse, blood pressure, respiratory rate. They might ask you to take blood pressure. Practice taking blood pressure 2 or 3 times before the exam. Peripheral signs on the face, again, they're not high yield. Where you're going to get your marks is by how you approach the chest, and if there's something abnormal on the chest, you're going to want to listen for a fair while to be able to hear the abnormality and figure out what it is. So don't like skim over the hands and face, but don't spend more time on it than you have to. Here's a few different things that you can look for there, but choose your own out of tallies and your phase guide. Position exposure, of course, even if you're not going to do it, tell the marker what you would do and why you would do it and why you're not doing it. So neck, JVP, carotids, don't worry about deviated trachea, that's not worth it in phase 1. Precordium, so look, feel, move. So inspection, that's what you're looking for. Palpating, if you just feel in 3 different spots, that's fine. And auscultate, you all know how to do, you all know where the areas are. You might have your particular pattern of doing it. At the end of the day, it doesn't matter as long as you hit all the areas. Dynamic Manoeuvres. So I was going to ask, but I've typed it up there already. So left lateral position, we listen because the apex is where you hear the mitral valve. And if you've got mitral regurgitation, it is loudest in that area and it radiates to the axilla. So that's why you do the left lateral position, because obviously with gravity, the heart falls against the chest wall there and you can hear it better. Upright and leaning forward, again, it's just gravity. The heart's leaning more towards the chest wall and you can hear it better. In aortic stenosis, it's going to radiate to the carotids. And inspiration right, so I and I, and expiration left. It's important to remember that it's the right heart, not the right side of the body. I'm really bad with my left and rights, and I spent 5 minutes going through this with my housemates last night just to figure it out. So if you're not confident about it, don't do it, because then the examiner will question you about it, and then if you get mixed up halfway through the exam with left and rights, it's a mess. Conclusion, so yeah, offer to help the patient sit up and get dressed, and always pause before you begin summarizing. Even if you're running out of time, you're better off doing half a good summary than rushing through a crappy summary. Any questions about the exam before we move on?
So what does it mean by like right heart versus the right body?
So now you've asked a tough question. So the tricuspid is left heart on left side of the body, yes. Pulmonary area. No, you know what? You're dead right. I got confused again. So right heart is tricuspid and pulmonary valves, right?
Okay.
And right heart is mitral and aortic valves. So just check that you're listening to the correct side of the heart, not the wrong right side of the body. But basically, I just know the motions. I don't know the explanation, and they won't ask you the explanation probably at phase 1. So just do left, expire all the way and listen. Right, inspire all the way and listen. Yes, I will double check and let you know if I'm wrong. Summarizing, keep it short and relevant. So the best way that I learned how to summarize was in fracture clinic on orthopedics because they are savage. So I got given an x-ray and they were like, okay, explain this x-ray. And I spent 5 minutes going through like all the different features of the x-ray and things that were normal and abnormal. They're like, okay, now do it again, but in half the time. Now do it again, now do it again. And after like the 4th or 5th time, I actually did it well. And they were like, okay, that is how you should be summarizing x-rays. And they gave me a new one, like, okay, try this one. And that only took me 3 times to summarize correctly. So to practice summarizing and to get good at it, don't just try lots of different summaries. Keep doing the same summary until you get it right, and then move on to a new one and keep doing the same one until you get it right. So never just summarize one patient once, summarize one patient perfectly. Some tips. Write down your patient's name and age at the start of the consultation. Everyone always forgets the patient's name. Start with the salient findings, always, because if you run out of time, you don't want to have not been able to, so you don't want to say, oh, around the room there were no abnormal signs, there was nothing abnormal in observation of the patient, there were no peripheral stigmata of disease, no clubbing, no tar staining, no splinter hemorrhages, and then you run out of time and you haven't even been able to talk about the chest. So start with what is important and then move on to relevant negatives. You don't have to list every single negative. A trap that some people fall into is that they weren't allowed to report back as they go. That rarely actually happens. Most doctors prefer you to report back as they go because then it's easier for them to check off the list. But if it does happen, then people say, oh, but I have to show that I know all these things and thought about all these things, so I'll mention them all in the summary, but you actually just end up losing marks in your summary. They saw you look for them. For bonus points, you can make a recommendation, prediction, request. Not necessary, but in cardio it's really easy because you just say, I would like to perform a lower limb vascular exam or respiratory exam and get an ECG and chest x-ray. And yeah, in general, practice. So an example, so Jennifer is a 56-year-old female who presented with a 3-day history of central crushing chest pain that radiated to the left arm and jaw. On examination, she had no abnormalities detected, there were no peripheral stigmata of disease, and heart sounds were dual with no murmurs. There were no risk factors identified in history and no other abnormalities noted. For completion, I'd like to perform a peripheral vascular examination, full respiratory examination, and get ECG, chest x-ray, and bloods. So keep it short, sweet, and relevant, and they'll be really impressed if you can do that at phase 1. Yeah. So that's it. Yeah, that's it. Any questions? Yeah.
I just had one. Someone told me previously that it could be worth just because in phase 1 OSCE that all the findings are going to be normal and that you could technically just memorize summaries for each system. Would you recommend doing that, or would you rather just?
I would highly recommend doing against that depending on who you are. I would have found it incredibly stressful. I tried to do it and it was really stressful because then you stress about getting every single word of your summary perfect and memorizing all of them, and then you end up standing there in the exam like looking at this and going, shit, what was the next word in that summary? I think being able to summarize what's in front of you effectively is more important. But also, a lot of the stations won't just be do a history and exam of the cardiovascular system. It'll be do a respiratory history and then a forced expiratory value and then take their temperature. So that's going to be very different to doing just a respiratory history and exam. So I think being able to adapt and do what's in front of you is much, much more valuable. You can try doing that, but I think that it might work for a few people. For most people, it will just make them more stressed.
You said to write down the patient's name and age when you get in there. Do they have paper and pen in it for you, or do you bring it in?
When I did it, we had a notebook. We all had our own notebook, and before we went in, they just flicked through to check that you didn't have any notes, and then you could take your own notebook in. Things may have changed, so double check with me. So
I think one of the other people said that they gave you paper.
it's very site dependent. I know for third year in Albury they gave us paper. For third year in Vinnie's they didn't. For second year we had to bring our own. I would just buy a notebook just in case and take it with you. In worst case scenario, they take it off you and give you a new piece of paper.
With summarizing, what is so you said some doctors prefer you to summarize as you go, some prefer you to summarize at the end. Is there any recommended way that med faculty prefers, or that is considered more correct in that situation?
A statement was put out by MedFac in 2017 that said that they didn't want you to summarize as you go, they wanted you to summarize at the end, but a lot of markers still said we want you to summarize as you go because that's how they do it everywhere else and in every other year level, and that's what the markers are used to. So being able to do both is really important. I personally much prefer doing it as you go. I find that you're able to tell the examiner a lot more. You make their job easier, because basically the easier you make the examiner's job to give you marks, the better that you'll do. And if you approach the exam with that mentality, you'll probably do quite well. So yeah, be able to do both. I prefer to summarize as you go. I think it's better generally, but the faculty might have come really hardline at the end. Yeah.
If you summarize as you go, do you still have to summarize at the end?
Yes.
Do you recommend like asking the doctor at the start, like, or do you just summarize as you go and see what they say?
This was a big controversy in my year. The thing that we landed on that was the best is, I'm going to summarize as I go if that's okay with you. And 90% of the time they say, yeah, that's fine. Or sometimes they say, no, summarize at the end. Yeah. If that's everything, I have to run. But since there are still 15 minutes left, can you guys practice taking a social history off each other using heads? Thanks. No. Nope.